An excellent and elaborate presentation from Dr. Sahai. He probably covered most of things, most of the things which was planning to say, and I'm going to focus probably on Indian experience and Indian data. Can I have my videos, please? Before I go to, I'm just going to take a glimpse of a video as to how it has advanced in last a decade. Maybe we started 12 years back. That time even gallbladder hernia or laparoscopic gastrectomy was very difficult. And if I can have a video, otherwise I'll start. In the same folder there is a video. Yes. So I'm going to just elaborate a short video presentation. This is edited to only 20 seconds from 20 minutes. So the procedure can now be done with mechanical devices. Anyone is same. So the same procedure now can be done almost in 20 to 25 minutes. You can see here the video. This is a large left lobe which shows the fatty liver. You can see the stomach's greater curvature is being devascularized by a vessel sealing instrument. You almost are unable to see a single drop of blood in the entire operation, in spite of patient being very high risk and super obese. This is one of the videos of the heaviest patient which is already posted on YouTube. That is what I am trying to show. This is now almost in few seconds we have reached the hiatus right from the pylorus. You can see this is the last cut. All the attachments of the stomach are detached, and then a long gastric calibration tube is then passed along the lesser curvature. Because it is done through probably 2 or 3 punctures only, and the punctures can be anesthetized, the patients almost can go home like a daycare procedure. You can see here the bougie place. You can see here this is a mechanical suturing device or a stapler which is suturing and dividing on either side. 2 or 3 firings, and we use reinforcement so there is not a single drop of blood, no need for any drains or catheters, and the patient practically can be discharged on the same day. You can disconnect and go back to presentation. So this is probably how it has evolved for us in last decade, a procedure where we had to learn procedure and initial time was 2 to 3 hours. It has come to 20 minutes, and that is why the complications have gone down. I'm going to focus on long-term results, but based on more of our Indian experience. If you date back to history, this was published way back in 1955 that amelioration of diabetes occurs following gastric surgery. Now, these procedures actually they are anatomical changes which induce subsequent physiological changes, add restriction and malabsorption. Most of these actions are almost permanent except for minor physiological adaptation of intestines. So the aim is to have intentional and sustained weight loss and related impacts of metabolic surgery. If you look at the history, dates back to as early as 1965, and I was happy to stay with a surgeon in LA who invented gastric bypass and did his first open bypass way back in 65. So even for the surgeons to get convinced and get started, it took from 1965 to probably 2000 for Indian surgeons to believe and get started. So long-term results even were available from 65. The evolution was open bariatric surgery to open gastric bypass, then gastric banding happened laparoscopically, then open duodenal switch. When it became difficult to perform a duodenal switch in super obese, laparoscopic sleeve gastrectomy became the first step, and that time we had the inventor of sleeve gastrectomy come to India. Fortunately, we met him. We did first 500 cases and published initial research on sleeve. Now it's almost 11 years that we did our first sleeve, and now I'm happy that in last 4 or 5 years it has become a standard of care. Then the metabolic actions became popular, and now it started being known as metabolic surgery. There are many novel procedures. Probably the future is also some endoscopic, minimally invasive procedure, just like how coronary bypass surgeries started getting replaced partly by the interventional cardiologist. In our experience, it's now more than 5,000 procedures since 2004. If you look at our long-term results, 4% weight regain at 5 years, and maybe 5% diabetes relapse, and Fortunately, we still don't have a mortality. That's because our clinical policy is that of International Center of Excellence. Few of our published long-term results: British 310 kg appeared in BBC as the heaviest British, again appeared 3 years later, who has lost almost 190 kilograms. This is one 3-year result. This is another one, again published by BBC as the youngest boy in the world to undergo bariatric surgery with successful long-term results. He has completed 8 years. You can see him 245 kgs. These are some of the long-term results which I am going to elaborate. Needless to say, everyone knows Dr. D.Y. Patil. He was 75 kg 5 years back with 5 angioplasties when I operated. And now it's 5 years complete. He's 80-year-old. He's been governor of Tripura, Bihar, from someone who was a wheelchair-bound person with severe orthopnea. This is one lady, one of our initial slaves, who has maintained up to 9 years. Another lady, we just met her after 10 years after gastric bypass. She came for umbilical hernia and gallstones, but because she had diabetes, severe dyslipidemia, we had done our initial gastric bypasses that time, and we found that 10 years later she almost is similar. This is another one from one of our initial studies, BMI 32, a patient of after gastric bypass, still off medications and still very active life. Now we are all worried about weight regain after these procedures. This graph shows what is physiological weight regain. If you look at aging, aging is known to reduce lean body mass, aging is known to slow down your basal metabolic rate, and that is why at the same time, with aging, the environmental factors, your comfort, your earning, everything goes up. Altogether, there is a slight increase in your weight for any normal person. So this is a physiological graph of aging and environmental factors. If someone undergoes surgery and comes back to some normal or maybe near normal healthy figure, just imagine the aging and the environmental factors are never influenced by surgery. They still persist. So this gradual curve of minor weight regain can continue in most of the patients. However, what we compare is what would have been the status at 10 years, 20 years, and what is the present status. And this is how the long-term results of any procedures are looked at. There are multiple studies which show that gastric bypass has excellent diabetes remission. Not only that, it shows that the remission occurs even before there is significant weight loss, almost at the time of discharge, that is few hours to few days. Another paper on 1160 patients where there was rapid resolution of diabetes. If you look at as a diabetologist, multiple actions in increasing the insulin sensitivity, increasing the adiponectin, reduction of inflammatory cytokines, reduction in hepatic steatosis, and so on, all these are permanent and long-term effects. And hence, if you look at the meta-analysis, there are 136 studies, and it showed that more malabsorptive procedures had extraordinary resolution. However, even simple procedures without any metabolic action had significantly better results than medical treatment. These are some of the published studies which show 9 years, 4 years, SOS 20 years. I am only going to focus more on some Indian studies than SOS. This was one of our papers published in 2010. That means we did this study in 2008, well before anyone was thinking of application of gastric bypass for treatment of non-morbidly obese diabetic patients. If you look at the patient's BMI was 22 to 35. This is published in American Journal. Type 2 diabetes confirmed with antibodies negative. Mean duration 9 years, 80% on insulin. So there were cases sort of given up that yes, if you want to do a study, these are patients where we are tired, you can still go ahead and try and enroll them in your clinical trial. The BMI dropped down to 23, almost by 20%. Hypertension improved, dyslipidemia improved. And if you look at this graph, this is how the glycemia improved. This is how the HbA1c dropped from 10 to 6.1, and this is almost in line with the idea position statement which is published now, which we heard in Dr. Shah's presentations earlier. If you look at the UKPD's projected risk reduction, there is significant risk in cardiovascular morbidity and mortality. In the bottom line, most of them had remission. I would say 100% had improvement at 3 months. This lasted for 9 months. However, now we have completed almost 4 years and we see better results. Some of the level 1 evidence published in New England Journal was mean grown study, Stampede, which Dr. Shah elaborated that bariatric surgery had better results as compared to standard or optimal lifestyle and medical treatment. What is important is even at 3 years outcomes, if you see the 3-year outcomes, probably at 3-year quality of life, glucose lowering medication and weight, all the three had favorable impact as compared to surgery in the form of sleeve or gastric bypass as compared to optimal lifestyle. I'm just quickly going to talk about 2 prospective control long-term studies. Most of you are aware about SOS study and look ahead study. Just elaborating some of the important points. 210 obese participants with BMI 34 and above and 38 in women. They were followed from 1987. So we are now almost completed 20-year results. 3 surgical procedures and patients who were matched and were in the standard medical treatment. If you look at this, everyone knows these graphs. These are controls, these are surgical arms. There was significant difference in percentage weight change. There was significant difference in triglycerides, HDL cholesterol and hypercholesterolemia. If you look at HDL, apart from exercise, probably it is the surgical intervention which had shown significant increase in HDL. Diabetes, hypertension and hyperuricemia, all up to 10 years. This was again published in JAMA. Total percentage excess weight loss was maximum in surgical patients, statistically more than the medical patients. If you look at even the 20-year results, the graph almost looks like 2 years, 10 years and 20 years. Even at 20 years, the surgical patients did far better than patients in the control arm. Even the fatal cardiovascular accidents and total cardiovascular events at 20 years were far lower in the surgical group as compared to the standard group. If you look at the mean changes in body weight after 2, 10, 15 and even 20 years, they were minus 23, minus 17, minus 16 and 18 in the surgical group as compared to almost 1% in the medical group, lasting up to 20 years. So bariatric surgery was associated with a long-term reduction in overall all-cause mortality, reduction in the incidence of diabetes, myocardial infarction, stroke, cancer. Even the incidence of new onset diabetes was lesser in these surgical patients. Of course, high insulin and high glucose at baseline were the predictors for favorable treatment effects and not the higher BMI, which we think at present probably that is why we tried to conduct some consensus conferences, because high BMI did not become the indicator for favorable outcome, and that is why the idea position statement. So this is probably from SOS study. Of course, the cardiovascular mortality, diabetes related mortality was significantly reduced at 7 years, published in the Adams et al. Study. So these were some of the studies, some Indian experience, our 1 decade of development of bariatric surgery, probably acceptance of bariatric surgery as a treatment of morbid obesity, then partly diabetes, and we just will be publishing our RCT, which is 3rd RCT after Stampede and Mean Grown, COSMATE, comparison of Indian diabetes, surgical treatment versus medical treatment. Of course, you heard ADA, IDF have started incorporating these guidelines in the standard of treatment. This year we have the 2nd Diabetes Surgery Summit on the 3rd World Congress for Interventional Therapies for Diabetes. Probably I tried to invite all of you for the Asian BMI consensus last year in September, where we did not come to a conclusion below a BMI of 30. However, I am very happy that beyond a BMI of 32, everyone agreed that if diabetes is uncontrolled and the body mass index is more than 32, probably early intervention is better than late. There are many such consensus meetings, and we had elaborate discussion about idea position statement earlier with Dr. Sahai. However, one very good news is, I must say, that ADA has accepted and endorsed the Diabetes Surgery Summit and approved to form new guidelines for treatment of diabetes with use of bariatric surgery. Probably I saved some time more for interaction and discussion than my presentation. Thank you so much.